Stain, rose Bengal stain is one of the stain which give you a good demarcation of the tumor line. The presence of keratin plaque is another very important feature of these lesions. One test I would always prefer doing in majority of the cases, particularly when I want to start topical therapy, and that is scleral fixity. It gives me an idea that whether the tumor is penetrating in the sclera or it is movable or just in a very early stage. So other than clinical examination, the gold standard for diagnosis of these lesions is the histopathological examination after excisional or incisional biopsy. Then non-invasive methods like impression cytology, but it gives very unpredictable results. UBM just to rule out any intraocular extension. And one most valuable tool for these lesions is spectral domain OCT, which gives you an idea of abrupt changes in epithelium and depth of the tumor. And especially when you are treating these patients with topical drugs, then it gives you really a good monitoring system. CT scan, when you suspect that there is a metastasis or extension of the tumor, then you should get the CT scan of the eye as well as the adjacent area. Now come to the management. We have two options, surgery or the medical management. Yes, surgery is a gold standard therapy for all the OSSN, irrespective of the cause and size, with wide surgical excision, with cryotherapy, and with or without adjunctive metabolites. If there is positive margin comes on histopathological examination, the chances of recurrence rate is very high. And in large tumors, it may cause limbal stem cell deficiency, scarring, and symblepharon formation. So here comes the role of topical therapy, which is fairly common nowadays. People are using it. This gives a few advantages over surgical management, like it avoids stem cell deficiency. It can treat a large area at one time. You can tighter with the concentration, and it can be repeated. So when to give these drugs, there can be used in various forms, like you can use for the reduction of the tumor, or you can use it as a prophylactic after surgical management, or as a prevention in a prophylactic period. So I prefer these topical drugs in cases of dysplasia and carcinoma in situ. In SCC, except when the patient is not suitable for the surgery, or if the lesion is multifocal, I want to reduce the size of the tumor before the surgery, I would prefer these drugs. Otherwise, I would straight away go for the surgery. So these are few indications when the tumor is recurrent, multifocal, involving the pupillary axis. These drugs are quite useful. So in our armamentarium, we have three main drugs: topical mitomycin C, interferon alpha 2B, and 5-fluorouracil. And other than that, there are many drugs documented in the literature, but of variable results. So one of the most ocular-friendly drug is interferon alpha 2B. It's a glycoprotein, and it has both antiviral and anti-tumor property. And it gives success rate 80% to 100% depending upon the the type of tumor. So this is the case of SCC. We actually done impression cytology in this case and found this result, and it was multifocal, involving the whole ocular surface and limbus. So this case responded very well to the topical interferon, and complete resolution was found within 3 months. Another case of gelatinous tumor with the pigmentation, and here also we got good results, and the whole tumor resolved within 3 months with few stippled pigmentation left over the surface. This is a case of leukoplakic. In leukoplakic OSSN, basically they respond very slow to any topical drugs, particularly interferon. They respond slightly faster to MMC, but you may need surgery in these cases. So we did a study on topical interferon alpha 2B as a single therapy for primary OSSN, and we found very good results. 91.6% cases responded to this, except few SCC and mucoid cases. So another therapy we have topical mitomycin C. It is little more toxic than the interferon, and it can be used as a primary or adjuvant therapy. It gives also 90 to 100% success rate depending upon the pattern of tumor. So it actually it's a faster drug than interferon, and it takes less time to resolve the tumor. But it is not very ocular friendly. Every patient would have complained something in the eye, foreign body sensation, to epithelial defect. So we compared both interferon and mitomycin as a primary therapy in primary OSSN, and we found that the success rate was comparable in both the groups, but the time period which MMC had taken was relatively statistically significantly less in comparison to interferon. And as far as adverse reaction is concerned, then all patients of MMC had some or other reaction in the eye, while interferon was really very friendly. Another drug is topical 5-fluorouracil. It is as toxic as MMC, but it gives very good response in the tumor, and within 2 months you can find the good response in these drugs. So these are few pictures which responded very well to the topical therapy. And now during topical therapy we need to assess a few important
please sum up, ma'am.
Yeah. Few important things during the course of treatment, and it's very important to see that whether the tumor is responding to your treatment or not. So if there is any change in the size, regression in the height, or regression in the vascularization, then continue the therapy. Otherwise stop the therapy and plan for the surgical management. And you can have resolution complete, partial, and there may not be any reduction. Recurrence may be present at the same site or different site after completion of therapy, and depending upon the drug you can find the ocular reaction, and you have to choose your drug accordingly. So there are some criteria on which you can choose your drug depending upon the size of lesion, its morphology, whether gelatinous, papillomatous or leukoplakic, and what is the status of ocular surface. If the surface is dry, not very well, then don't go for mitomycin or 5-fluorouracil kind of therapy. Cost is another factor, and patient should be very compliant if you are going to start topical therapy in these patients and follow up. So these are the drugs, upcoming drugs, or people are using nowadays very frequently, and it's a viable option in the treatment of OSSN, either as a primary treatment or as a part of chemo reduction or as a prophylactic after the surgery. Thank you so much.
Thank you, Dr. Rakhi. What is your experience regarding cases of, like you mentioned about certain cases of SCC, so you've never tried that in SCCs, only in carcinoma in situ?
No, we tried. We tried the first case I shown, which was treated with topical interferon. It was a case of SCC with multifocal appearance involving the fornices also. But the point is, SCC with good height and large tumor, they actually don't respond to any drug, neither interferon or mitomycin or fluorouracil. But the lesion is flat, involving the limbus, gelatinous kind of lesion, they respond very well to any treatment, any topical treatment.
Especially regarding mitomycin, I just wanted to know, if you put the patient on topical, have you seen any scleral melts or kind of a complication? Because sometimes they will not be compliant, and they just keep using that drug.
Yes, that is, it's very important thing to see whether the patient is compliant or not. Sometimes people have been put on this drug topical treatment, and they keep using it and forgot for the follow-up part. So when they come after 2 or 3 months, either they have a very red or toxic eye, or the size of tumor has been increased a lot. So it's very important to keep the patient under follow-up, and mitomycin I have not experienced any scleral melt in topical mitomycin as per my experience. But yes, it gives a very toxic ocular surface, and you have to start sometime loteprednol along with mitomycin C2.
Varying the doses also of mitomycin C in cases when they are not responding. Have
yes,
you tried
I have
increasing the dose?
I have done. I have usually I give 0.04%, but in some cases I started 0.02%, but 0.02% I don't think so it's work.
For carcinoma C2?
Yeah, it can displace
yes. Cases which are still like you have precious cytology for every case before you start treatment.
It can. For dysplastic early cases or carcinoma in situ, it can if the size of a small tumor is small and relatively flat. We can use mitomycin C at lower concentration, just to avoid ocular toxicity.
So what is usual regimen for mitomycin C in such type of cases?
Mitomycin C I use 0.04%. Nowadays, I'm not using mitomycin C at all, because I see more of complication rather than some good response from the patients. So 1 week off and 1 week on mitomycin, and I usually start low dose surface steroid along with the topical mitomycin C. But in case of interferon, I don't find any complication, and gelatinous tumor are the tumors which 100% respond to these therapies.
In interferon also you take 1 week off and on and...
No, interferon you can give continuously without any complications. Sometimes patients feel little bit of conjunctivitis follicular, otherwise they don't get any kind of ocular side effect. It's very good drug.
Cost difference?
Cost difference is quite significant. Interferon, the whole therapy actually take around 3,000 to 4,000 or up to 5,000 rupees. Mitomycin is very cheap drug.
But you will give those, you will reconstitute those drops and give them, or?
Interferon, you can give multiple concentration, but preferably 1 million international unit. And it comes, one vial has 3 million international units. So you have to dilute 1 ml with the 2 ml of saline or distilled water.
Because mitomycin usually the 10 ml vial.
Yeah, mitomycin comes in a powder form, and you have to reconstitute it with 5 ml of distilled water.
People started using mitomycin post-operatively to avoid, to prevent recurrent pterygium. But then these scleral melts and these things were common. Even in trabeculectomies, you find a lot of, late bleb leaks and all that. So mitomycin is a drug which is very toxic and continues to affect the
and
the
patients are not compliant with mitomycin because
Yes.
they don't feel comfortable after putting the drops.
Yeah.
Only thing is cost factor.
Yes,
That
cost is
very
important. So better to
significant.
go for surgery rather than putting them on
So is there
mitomycin C.
any condition in which you directly put patient on surgery rather than putting first the chemotherapy
Suppose,
and then go for
first
surgery?
of all, if suppose I'm treating, I'm not, I don't treat now leukoplakic with topical or any tumor which has a great height like mucoepidermoid or it's looking like SCC, then I don't go for topical therapy except in cases when the patient is not fit for surgery immediately and we want some chemo reduction or just for the time being. Otherwise, what did you ask?
Directly go for surgery without
Yes,
putting the
yes. So
patient
in
on
these
chemo
cases,
reduction.
I go for the surgery, or in cases suppose gelatinous is there, flat tumor involving the whole limbal stem cell, then I go for straight away go for topical. If patient cannot afford the treatment, suppose topical interferon, in these cases you can also go for 5-FU, which is one of the cheapest drug, 5-FU, and mitomycin C for 1 month or 2 months with topical steroids. Other than that, all tumors has to be surgically excised.
Okay. Thank you, Dr. Rakhi, for